Dr Gretel Davidson, outgoing New Fellow Representative on the board of the Faculty of Pain Medicine at the Australian and New Zealand College of Anaesthetists. In this interview, I'm talking with Professor Pamela Macintyre, who is a Foundation Fellow of the fledgling faculty and a member of the inaugural board. Graduating from medicine at the University of Tasmania in 1974, Professor Macintyre followed that up with a fellowship in anaesthesia in 1981 and a Masters of Health Administration at the University of New South Wales. She was the acute pain lead for curriculum redevelopments with ANZCA, as well as being involved in the initial curriculum development for the Faculty of Pain Medicine. Professor Macintyre's career has been dotted with achievements and awards, notably the Robert Orton Medal in 2005, ANZCA's highest award for contributions to anaesthesia and pain medicine. Pain management was an emerging field when you started your career as a specialist anaesthetist, which made you a forerunner in your field. What got you interested in acute pain management?
So I'd been exposed a little bit to chronic and cancer pain management when I did a locum consultant job at Flinders Medical Centre after I finished my anaesthetic exams. There were no palliative care services, so when the doctors in the pain clinic were away for conferences, I sometimes covered not to see patients with chronic pain, but those with cancer pain. I decided I'd like to work abroad and spent a couple of years in Seattle following on the footsteps of a couple of colleagues from Flinders, partly because it was a major trauma centre, but also because they did about 50% of the patients had some kind of regional block. At the time, we did lots of epidural analgesia, anaesthesia and arm blocks at Flinders, but it meant that I got exposed to lots of patients had leg blocks. We did lots of paravertebral blocks. They could have their fractured mandible fixed just under a block. So it was really very interesting. But we were allowed one day a week there to do what we wanted. And I chose to spend most of the time at the pain management unit in Seattle, which was the first multidisciplinary pain clinic in the world. You probably know it was set up by John Bonica, who'd retired by the time I got there. So I met Brian Reddy, who later on, just as I was leaving, was starting up the first acute pain service in the world. But knowing him was really another coincidence that helped me get ours running, I guess.
Explain why acute pain management became an area of interest addressed by anaesthetists.
Two things. Most of the chronic pain, or not, if not all the chronic pain doctors at the time were anaesthetists. And also anaesthetists were, and still are, the leaders in regional analgesia and anaesthesia. We're used to working with colleagues across all specialties, from surgeons, physicians, intensive care medicine doctors, emergency medicine. And a lot of what we use, some of the medications, not just opioids, but others like ketamine, are really an extension from the operating theatre. So I think probably based on our anaesthetic knowledge and regional analgesia in particular is why it fell to anaesthetists in the first place.
There were no other acute pain services in Australasia, when you started the one at Royal Adelaide. How did you go about starting it?
The idea absolutely wasn't mine. I didn't, when I was leaving Seattle, I did not know that Brian Reddy was just thinking about starting only a couple of months later, their acute pain service. Our professor at the time and the head of our chronic pain service, Bruce Ransfeld, had heard about acute pain services, heard from Brian Reddy at a conference overseas. And the professor was then able to get some funding to enable us to start an acute pain service. He asked the whole of the department who was interested in getting things going. And really, I just thought, why not? We did think, firstly, though, that getting everyone on board was vital. So we had a small group in the department who worked on it. We sent out a survey. We asked, obviously, I went to the Director of Nursing to explain what we would be asking of the nurses in the general wards, and she was very keen to back it. We also sent a questionnaire to surgeons saying, would you like, explaining what an acute pain service could offer, would you like it? And to our surprise, the vast majority of those who replied said, yes, please, get it going. And even when we resurveyed them 5 years later, well over 95% of those who replied said, terrific service, keep going. But I think it was just getting everyone on board, and also the pharmacists, the drug committees. As I said, I knew Brian Reddy. I figured it was probably silly to reinvent the wheel, so I was able to go back to Seattle, shadow them on their acute pain rounds for a couple of weeks. And he and his team very generously loaded me up with copies of all of their educational materials, all of their nursing procedure protocols, all of their standard order sets. So really, I didn't have to start from scratch. We changed things along the way, but it was because of their help, I think, that we were able to get it going reasonably quickly with techniques and instructions that were tried and true. There was only one big difference. In America, the funding of the department depends still, even in public hospitals, depends on patient billing. We're not constrained by that. So I thought, as rather than just take care of patients who the surgeons referred to the acute pain service or other doctors, that it would be a good opportunity at the time to try and improve acute pain management throughout all of the hospital. One of our differences is I thought we shouldn't just concentrate on patients referred to the acute pain service, but try and improve things across the board.
It seems remarkable now to look back and think that acute pain services didn't exist and think about how surgical and other patients must have been managed in the absence of that.
When I was an intern way back, we had no teaching really as medical students. And our teaching for pain management, my first ward was a surgical ward, and the surgical registrar literally said, for pain management, here's Omnipon, which was a funny mixture of, very old mixture of morphine plus, and pethidine. And basically he said, look, you give men a whole ampoule and women half to three quarters of an ampoule, 4 to 6 hourly if they really need it. And that was pain teaching.
You mentioned the role of nurses in the team. Can you explain, for those who may not have been involved, the role of the nurses and why they're so important?
They're the key, I think, to running of an acute pain service. We just couldn't do it without them. They're the key to nursing education for a start related to APS techniques, but also I think they're the key to improving pain management, acute pain management throughout the hospital, as I said, which is what we were trying to do. I know that our acute pain service nurses, I'm retired now, but our nurses were, for many years, got a number of sessions in the nursing orientation when there were new nurses coming into the hospital. And they taught them about general things like patient assessment, not just titrating opioids to pain scores, but looking at functional activity, how to minimise the risks of opioid-induced ventilatory impairment or so on. They're also the key, certainly they were in our service, to continuity of patient care. The way we were set up, we had a different consultant every day. Most of us had a fixed day a week, but it was variable, so they were the key to continuity of care. Along with, later on, we got anaesthetic trainees for a week at a time, and that was always helpful. So the nurses are absolutely pivotal to good acute pain management in the hospital, and now they're taking up the baton of opioid stewardship throughout the hospital in many centres.
Opioids have been a topic of intense debate throughout your career. Can you outline how the attitude to prescribing has changed over the decades?
This shows, I think, that I've probably been around too long. I was there to see the initial considerable underprescribing of opioids for all pain, acute, chronic and pansa pain. Now, then saw the pendulum swinging way too far to the liberal overuse of opioids, particularly for the management of chronic pain. And I think one of the issues now, and because the words opioid epidemic strike fear into the hearts of many, one of the dangers is that the pendulum is swinging too far back to the don't use opioids if at all possible. I absolutely agree that for the management of chronic pain, opioids should not be first-line medication, and that's consistent with the Faculty of Pain Medicine Professional Standard document. I think it's PM01, I can't remember. It's consistent with the revised Therapeutic Goods Administration guidelines. But in the acute pain setting, the fact that there's been an opioid epidemic has led some to try to significantly reduce opioid use, or especially go for opioid-free anaesthesia, analgesia. There is very good evidence for the benefits of multimodal analgesia and opioid-sparing techniques, but there is much less, if any, good evidence at all for opioid-free anaesthesia, analgesia, especially in patients having major surgery. So I think somehow we have to recognise, in the acute pain setting at least, opioids are needed in some patients. They are beneficial in some patients. what is needed is better opioid stewardship overall. I think ANZCA and the Faculty of Pain Medicine are actually helping to show what is needed along with a good evidence base.
I also personally think that one of the important factors is the individualisation of it. There's a great individual variation in requirements that I feel sometimes gets missed in protocolisation.
It does. We, as I said, just when I had to enter, one of the requirements for continued funding for the acute pain service was that I had to meet certain, I guess these days they'd be called key performance indicators, but we had to meet certain requirements and report them to the health department. And one of the things I had to do was enter patient data into a very old-fashioned database, and it became very obvious early on that the older patients got, the less they seemed to need, even though their pain relief was, if anything, a little bit better. We were going on pain scores at the time. But we also recognised that there was a huge, huge interpatient variation in each age group, so 8 to 10-fold in each age group. So the idea of doing fixed dosing and expecting it to work for everyone is wrong. It's not going to. There is a huge interpatient variation, and not the dose requirement difference is probably a pharmacodynamic thing. The older brain gets more sensitive to opioids. But the other thing I think we hugely underestimate, especially in the acute pain setting, is the variability due to other factors, particularly some of the psychological comorbidities such as anxiety, catastrophizing, depression. So I think we've got better, but we need to be better still at individualising patient treatment.
Now, one of the things that you are best known for is your involvement in the Bible of Acute Pain Management, the Acute Pain Management Scientific Evidence, which is now in its 5th edition. Can you tell us about its evolution and your role in its production?
It really started, I have to say first up, that Michael Cousins, who was the first dean of the faculty, played a huge role. Right from the beginning, it was a multi-specialty, multidisciplinary effort. So we had input from physicians, surgeons, physiotherapists, psychologists, and so on. It was a much smaller book than it is now because there was little good evidence at the time. He kindly then put my name forward to lead the 2nd edition, which was published in 2005. And then I also led the 3rd edition, published in 2010, before handing over to Stefan Schug, who ran with the 4th and 5th editions. As I said, Michael Cousins, I just wanted to say a thank you to him, really. He was the push behind most of these innovations.
You also wrote a book on acute pain management, the Acute Pain Management Practical Guide. What prompted you to do this?
Just coincidence again. From the early 1990s, I'd been able to get some teaching sessions with medical students. Initially, amazingly, I was invited by one of the orthopaedic surgeons to join their Friday afternoon case discussion sessions so we could take the students through acute pain management. Around the mid-90s, it was about 1994, I worked with the head of the chronic pain service, Bruce Rounsfeld, the head of palliative care services, Mary Brooksbank, and we were able to get a week of pain for all medical students. It's done in 6 blocks throughout the year, but we thought it was a good idea to teach them acute pain, chronic pain and palliative care. The problem was there were no textbooks that I could advise the students to use, and I used to make my own student notes that were getting bigger and bigger and bigger. And it just so happened there was a commissioning editor from one of the publishing companies in the UK travelling around Australia, going to various anaesthetic departments, saying, what kind of books do you think are needed? And I showed her my notes and said, somebody just has to do an acute pain management book because I don't have one to recommend to students. And she said, well, you could do it. And I said, no, I couldn't. But later on, I thought, why not give it a go? Brian Reddy, I had to initially have a co-author who was well known. And again, I was just lucky that Brian Reddy agreed to be that co-author. So it was his name that helped carry the first 2 editions. Stefan Schug then joined me for the 3rd, 4th and 5th editions. And he and I have both retired. The last edition was in 2021. I thought that would be the end of the book, but the publishing company was very keen to keep it going. So I'm very lucky that I've just signed a contract, and Jenny Stevens from Sydney, who I'm sure everyone knows well, Jane Quinlan, who's a good colleague and a really excellent anaesthetists. They're both anaesthetists and pain medicine physicians from Oxford have agreed to be my co-authors. And then the addition after that, because I will be way too old, they can carry on by themselves if they would like to. So just coincidence and luck, really. I called it a practical guide because ever since I was a medical student, I've really not got my head around CNS physiology particularly well, and I thought if I called it practical guide, I wouldn't have to have any chapters on physiology.
You have obviously had a big role in education throughout your career. Where do you think are the important places to target effective education to improve acute pain management?
The education needs to target every clinician who's involved in the care of the patient. So primary nurses, but also pharmacists, physiotherapists and others, and ideally from their student years. Everyone needs to be aware of how acute pain management is managed, at least in their hospital, but also hopefully in an evidence-based way, because we all need to be aiming for the same thing, saying the same thing to patients. From the medical side of things, this meant starting with medical students. From 1993, I was able to start teaching those students. As I said, we then went to a pain week, and I also get time still in their final year to do some practical prescribing sessions, also some case discussions around cases, more problematic cases that have arisen where interns have been called to see the patients in the middle of the night. So they need to have some strategies to help them through that, if nothing else, who to contact. I think also it's important to give patients, their carers and families appropriate education. These days, especially with Dr. Google and various websites, expectations of what we can offer or achieve can differ markedly from what we actually can do or what can be achieved. And it may start with something as simple as saying, we don't expect to be able to abolish all of your pain. Some discomfort is to be expected, but what we will do is help you get back to your normal function as soon as possible. So I think patient education, ideally if they're having elective surgery, starting prior to surgery, but all throughout and at the time of discharge. I think everyone involved, including the patient, needs to be on the same page.
Now, another interesting aspect is your involvement in prison health. Prisons have been a problem with regards to opiate and substance use, and I understand that you've been involved with prison health in South Australia and some of the changes that have been brought about.
I stopped doing anaesthetics, a good 12 years before I retired, and I just did 0.75 FT, and I did acute pain rounds and anaesthetic outpatients. And I saw a patient one day who was a prisoner, and there were 2 prison guards with him, and he was scheduled for day surgery for repair of an epigastric hernia. And I asked him how big the incision the surgeon thought it would be, and he showed me with his hands, but it was going to be probably a good 10 centimetres. So I asked the prison guards what pain relief he could have when he went back to the prison infirmary, and the 2 guards were absolutely lovely and said not much. He would be lucky to get paracetamol and a non-steroidal anti-inflammatory drug maybe twice a day. So they were getting totally inadequate pain relief. So I said to the prisoner, you're going to have to stay in hospital because you may need some opioid and you may be in for a couple of days. The prison guards thought that was a terrific idea. They were really nice. So I got him admitted as an inpatient. Then I spoke with the head of our department about this and our department in general, and a memo went out from our department saying if prisoners were coming to have surgery and would need an opioid, they needed to stay in hospital. So very quickly they were able to introduce regular paracetamol, say 3 times a day of the extended release, regular non-steroidal anti-inflammatory drugs, sometimes some tramadol or 4-hourly PRN oxycodone. It's, I think, worked out well for the patients. The nurses really were grateful that they could provide proper nursing care. Unfortunately, I think it was really precipitated by money, but nevertheless, the outcome was very good.
Roughly when was this? How long ago?
It was after we'd introduced the immediate release opioid order and monitoring chart, probably about 10 years ago.
Now, you just mentioned the ordering and monitoring chart for PRN opioids, which I understand was another one of your initiatives. Can you explain what this was and why it was necessary and how it sort of became developed?
I guess, as I said, we started our acute pain service in 1989, and we knew by 1992 that we needed to base initial opioid doses, immediate release opioid doses, on patient age at least. But we also realised early on that the key to safer opioid titration involved monitoring of a patient's level of sedation. And pretty much from then on, ignoring their respiratory rate. We'd obviously always done this for patients under the care of the APS, having at that time primarily PCA, or around 25% of patients were getting epidural analgesia. But it seemed silly, as well as unsafe, not to do the same monitoring for any patient in the hospital given an opioid for their acute pain. So we got a flowchart approved by the drug committee initially to show what monitoring was needed, when it should be done relative to the time of administration. It was approved in 1994. It was not followed. So we developed a specific immediate release opioid monitoring chart, which was supposed to be used side by side with the prescription. That too was not used. So it took a while, but a pharmacist and I put together a combined order and monitoring chart that looked just like the ones we used for PCA and epidural and other regional analgesia, because the nurses in the surgical wards at least were very familiar with this format. And like the acute pain service charts, the immediate release opioid ones not only had the opioid prescription on it, but helped guide the nurses in terms of when doses might need to be increased, when doses had to be decreased. It introduced the need for pain scores, but also functional activity scores. So back in 2010, sedation scoring, it included warnings about adding sedative medications to a patient given opioids unless it was absolutely necessary. Things like, just because a patient records high pain scores doesn't mean more opioid is needed. You need to look at a patient's functional activity. And there was also a pre-printed order for naloxone. I checked with the Director of Nursing before trialling this, because we thought it was very likely that it would mean an increase in nursing workload, but she was incredibly keen to trial it. So we did. We trialled it in a medical ward and a surgical ward in 2 different hospitals. And the feedback from the nurses was actually incredibly and overwhelmingly positive. Many of them said in free text that it actually made them feel much more empowered to better titrate opioids to patient requirements. So after a trial in the surgical medical wards, it was introduced to these hospitals.
What is your feeling about how electronic medical records have changed things in hospitals in terms of prescribing?
We didn't start the EMR system until we moved to the New Royal Adelaide Hospital, and we started with it just for patient case notes initially. I retired not long after the prescribing aspect was introduced into Sunrise, which is the EMR system at the hospital. So I didn't use them all that much, except enough to know that at school I seriously should have done a touch typing course, and my parents assured me that I would absolutely never need to know how to type. Because our immediate release opioid paper form was 2010, we didn't start EMR prescribing until, I think, 2019. That form had been in use for some time, and so very thankfully it was felt only logical to underpin the information in what was to be used in the EMR system in Sunrise. What we did was develop an adult acute pain order set, which the junior doctors are told to use rather than select individual drugs from the drug catalogue.
Many of us who've worked in acute pain services know about the difficulties of some of the patients, the more complex patients with underlying chronic pain problems or substance use issues. Can you explain what is it about these patients that are particularly challenging, and how do you think they can be best approached in our hospitals?
They can be challenging. I still think we need to recognise that treatment should be patient-centred and that patient input, where possible, is appropriate. By and large, if we stick to using general opioid stewardship and evidence-based principles, I think it's reasonable. We need to not be pressured into deviating from what we think is good practice for any patient. So, for example, we need to look at sensible prescribing on discharge, and there will be some patients that maybe should not be given immediate release oxycodone, for example, to take home to self-administer. It may be that some of them need to pick it up from a pharmacy on a daily basis. If we're seeing a patient who has chronic pain, and particularly if they've been prescribed an opioid for chronic pain, I think it's worth setting expectations right from the beginning, ideally even before surgery, that our aim is to help you manage your acute pain while you're in hospital. Given that you and your doctor have got a plan to manage your chronic pain, we're not going to interfere with that. Now, sometimes we had to if some of the doses were extraordinarily inappropriate. I remember we had a patient on 1,600 milligrams of tramadol a day, and I was not going to prescribe that in hospital. But just make it clear that we're going to leave the chronic pain management up to you and your doctor. They've been doing a good job up to now. We're just going to look at chronic pain. So I think treating them as individual patients, but also setting reasonable boundaries, which are evidence-based where possible, and also making sure that every member of the treating team, be it the nurses, the surgeons, the pharmacists, the acute pain service, are working together saying the same thing so that there's minimal risk of splitting, and not meaning that very problematic patients can play one person off against another or one team off against another. Firm but fair treatment, evidence-based treatment, is still the way to go.
I think one of the really important things to keep in mind also is that when a patient has chronic pain, they can also have acute pain of a different source or nature that needs to be managed as it presents, and not just, well, this is a patient with chronic pain.
When patients first present to an emergency department, there's still often an inadequate distinction made between new acute pain and an acute pain flare. So that if someone comes in, they've got chronic back pain and they have an acute pain flare, loading them up with intravenous opioids is not the answer. But if they've been in an accident and they really have new acute back pain, they may need that. So we just have to be a little bit careful and non-judgmental, but set firm, sensible boundaries as we would for any patient.
Discharge prescriptions for opioids have been particularly problematic in the community. Can you explain the way that the systems have evolved, why there have been problems, and what things are now in place to try to remedy this?
Absolutely. They've been problematic. Back in 2009, so some time ago, I was asked to be involved in a survey that was done by a couple of the pharmacists looking at discharge opioid prescriptions after surgery. And this survey showed that a lot of patients were being sent home with much more opioid than they needed. We introduced opioid prescribing guidelines, for example, in 2010, saying patients shouldn't go home with more than they used the day before they leave. And the formal instructions meant the ward pharmacists could actually say to the interns or the other doctors, we're not dispensing this discharge prescription because it exceeds an appropriate amount of oxycodone. They are also helping, for example, identifying opioid dose trajectories that are not decreasing, so that can be investigated long before the patient leaves hospital. Also, where opioids are overprescribed, there can be a huge reservoir that remains of opioid. Normally, it's not taken back to the pharmacy or disposed of, and that reservoir is at risk of being used for non-medical reasons by not just the patient, but maybe friends, family, or others. So we wrote guidelines for opioid prescribing on discharge in 2010 that were then adopted for statewide use, that did restrict, as national guidelines now say, the clinical care standards from the Australian Commission for Safety and Quality in Healthcare that were published, which say opioid discharge doses should be based on a patient's prior 24-hour requirements. The other big issue was, with discharge medications as well as in hospital, was the use of slow-release opioids for acute pain management. And we now know that compared with immediate-release opioids for acute pain, slow-release formulations lead to less effective pain relief. They lead to higher opioid dose requirements and a higher risk of adverse effects, but they also meant a higher risk of persistent opioid use after discharge. We were lucky because we didn't ever go down the slow-release opioid path for acute pain management in the first place.
My final question is, what do you see currently as the big challenges in the world of acute pain management?
I guess opioids is still the big one. I think we need to pay more attention to whether or not there's a good evidence base from what we do. I know, for example, with slow-release opioids, with perioperative gabapentinoids, a lot of the information we got was from drug companies. It wasn't always pertinent, to be polite. So we need to know what we're doing has a good evidence base where possible. For example, if we'd thought a lot more about introducing slow-release opioids for the management of acute pain before introducing routine perioperative use of gabapentinoids, because the doses that were being used in the studies were huge doses, single doses of 150 milligrams or 300 milligrams of pregabalin to older patients having major joint arthroplasty. Anyone who's prescribed pregabalin would know that we would normally start those patients off at 25 milligrams maybe. They were bound to increase sedation and increase the risk of opioid-induced ventilatory impairment, just as slow-release opioids were. So I think we need to not just take things from drug companies, but actually, if there's no evidence, just go back to the basic pharmacology. As an anaesthetist, I think it's sometimes difficult that drugs or regional blocks may not be the answer to every problem in acute pain. We've been trying for over 2 decades to get a pharmacological way to prevent or reduce the risk of chronic pain after surgery, with very little in the way of good results. Yet some of the predictors of the risk of development of chronic pain after surgery, psychological comorbidities, for example, like catastrophizing anxiety, depression, and I just can't help feeling we might get further if we could help patients better manage these and not just add another needle somewhere or another drug somewhere, and possibly change what we've been doing, even what we've been doing for some years.
And touching on what you were just saying about the other factors that contribute to the chronicity of pain is patient expectations. And if a patient expects no pain after surgery, if they're catastrophized, that pain is likely to become more problematic. If they have a reasonable expectation, then they're less likely to be concerned about it.
I admit that is much easier said than done, but I think we shouldn't just be focused on new medications, new interventional techniques.
Thank you very much for your time, sharing your wisdom and expertise.
Thanks so much, Gretel. It's very kind of you.